Hello, I'm Jan Leifman.
And I am Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Alok Khorana. Dr. Khorana is the Sondra and Stephen Harris Endowed Chair in Oncology Research, the Vice Chair of the Taussig Cancer Institute, Director of the GI Malignancies Program at the Cleveland Clinic Lerner School of Medicine of Case Western Reserve University.
In today's presentation, Dr. Khorana discusses the microbiomic interplay in young onset of colorectal cancers.
Did you know that Dr. Khorana is the author of the Khorana Risk Score for venous thromboembolism in cancer patients?
A true inspiration in the field of medicine.
So let's tune in and learn from this global leader.
Another way we can get insights into understanding young onset colorectal cancer is from understanding the microbiome. So as I'm sure all of you know by now, microbiome is exceedingly important for diagnosis of the cancer, for understanding the prognosis, factors placing it into remission, and potentially in the future for choosing therapy or other interventions. And the microbiome is affected by many different things. Diet obviously is a factor that affects microbiomes. In cancer patients, the type of chemotherapy that we use, immune checkpoint inhibitors, can affect the microbiome. Medications administered during treatment, including antibiotics, may affect the microbiome. And when we say microbiome, we actually mean two different microbiomes. We mean the tumor microbiome, so the microorganisms present within tumor cells themselves. And then we mean the fecal microbiome or the gut microbiome, which may have an impact on prognosis and response to treatment as well. We've seen already sort of these different early life exposures, and one theory is that many of these, the so-called exposomes, so the different things that you're exposed to in the prenatal, natal, postnatal, early childhood, adolescence, young adulthood phase, may in fact act by the development of the microbiome. And some factors, some elements in the exposome, such as the global westernization of diet, unhealthy cooking practices, greater consumption of red and processed meats, synthetic dyes, and so on, may alter the microbiome towards greater immunity and inflammation, which would lead to more cancer, may lead to obesity, which can predispose to cancer, may lead to diabetes, which can also predispose to cancer in adulthood. And so the theory is that at different portions of the process, from normal colonic mucosa to initiation of DNA damage, to promotion and proliferation of cells, and to progression, different bacteria may, or microorganisms may impact pathogenesis differently. And that's kind of hypothesized on here based on some data that's becoming available. And so this whole concept that that we move from a homeostatic system, as shown on the left, to sort of maladaptive behavior, which leads to barrier dysfunction, which can lead to inflammation, which can lead to hyperplasia, and eventually to tumor, driven again by different microorganisms at different phases during this process, which lead to a different interaction with the immune system, which in turn either helps or hinders the immune process. This understanding is starting to gather momentum. And in fact, we see that if we study microbiomic profiles in colorectal cancer, some types of microorganisms are increased. Those are listed on the left and commonly include B. fragilis, E. coli, and E. faecalis. And some are decreased, and they commonly include lactobacillus, clostridium, and a couple other ones. And these different stages can influence these specific bacteria and their products. So to understand this better, we conducted a tumor microbiome analysis of young onset colorectal cancers versus average onset. Here we define young onset as the same as before, age less than 50. We define average onset, trying to get some separation between the two categories, as older than age 60. And these data were presented by one of our fellows here, Shimoli Barod, just a couple months ago at ASCO GI. We actually had a very large sample size of about 300 plus patients with different stages of colorectal cancer. We excluded some cases because they were either non-malignant or did not have adenocarcinoma, or they were from metastases. So we wanted only the primary. And we took fresh frozen tissue from the primary tumor. We also took paired adjacent non-malignant tissue as control. And so we had a within, in each person, we had a within person control, which was not cancerous. We isolated 16S rDNA and sequence trees were assigned to sort of genus level, and sequence variants were analyzed for alpha and beta diversity. And I'll show you that in a second. And then we did a bunch of corrections and correlation analysis. So here's the characteristics of the patients. Young onset and average onset do differ clinically. And you see, as has been shown in many other studies, that young onset is more likely to be a left-sided tumor, so more rectal cancer, more likely to present with advanced stage, so more stage 4 disease. And because they're more likely to have rectal cancer, they're also more likely to receive neoadjuvant treatment. And certainly all of these things could potentially impact on the microbiomic analysis. On the other hand, this is how young onset patients present. They are different in clinical presentation as compared to usual onset colorectal cancer. So you can't artificially sort of compensate for that. I think you have to accept that. What we found was that if you look at patients above 50 versus above 60, versus under 50, alpha diversity was clearly different. As you can see in the graph on the left, alpha diversity is the diversity of microbial species within the tumor. And then beta diversity was also different. This is differences in microbial diversity between patients. So one is within patients, one is between patients. And you can see both of these exhibited quite different diversity profiles, suggesting that microbiomic profiles in younger patients were somewhat different. And when we went to the taxa level, we found the relative abundance units of different taxa were different. And you can see this in the profiles here, under 50 on the left, above 60 on the right. And without going through sort of each genus here, I want to point out a couple. Akkermansia was much more prevalent in young onset disease compared to average onset. Bacillus was less prevalent in young onset. And then E. coli and Shigella were also less common in young onset compared to adult onset. Pseudomonas was somewhat greater in young onset versus average onset. But the big news was Akkermansia had probably the highest difference in terms of significance between young onset and average onset. We've also done a network analysis, the results of which you can see here. This sort of provides you with some correlation between the different bacteria or microorganisms, I should say. Patients under age 50 on the left, above age 60 on the right. And the different colored sort of bacteria are shown differently. And you can see these patterns in terms of network analysis are also different for younger versus older patients. So sort of summarize the microbiomic profiling of young onset versus average onset colorectal cancer. When controlling for normal tissue microbiome, we still saw a significant variation in the intratumor microbiome between young versus average onset patients. The presence of Akkermansia, which is generally considered a healthy gut organism, was correlated with improved overall survival in young onset patients and was more prevalent in young onset patients compared to average onset. And as has been shown previously, young onset patients had more left-sided tumors, low-grade tumors, and advanced stage tumors at presentation, and were more significantly likely to receive neoadjuvant therapy as compared to average onset disease. What do the implications of this type of microbiome have on, in terms of interventions? Well, if we better understand microbiomes of patients who are less likely to get cancer, or who, even if they get cancer, are likely to do better, it gives us an understanding of the disease state. It gives us an understanding of the disease state when it is active and when it is in remission. It also can provide us with biomarkers. So if we see certain microbiomic profiles change, and that's predictive of getting cancer, then that would, in the future, potentially provide us with clues as to which patients to intervene in or which patients to screen. And potentially we could intervene. We could say, hey, here, take these specific microbiomes, and this would reduce your risk of colorectal cancer. I think that's sort of the possibility as we move forward, or go to sort of a polymicrobial type of approach that, generally speaking, if you have more alpha diversity, then you would have less chance of getting colorectal cancer. So these are, diet-assisted microbiome engineering approaches that are currently being considered, and I don't think they're as far off in the future as we might think. We can also track temporal trends in human host using the gut microbiome and diet. As you see, the diet trends have changed recently with plant-based diets and plant source diversity going up and meat-based diets and processed diets going down. And what does that do to the microbiome? That's also a sort of diet-assisted microbiome engineering, right? You're changing the microbiome of the gut based on the change in the diet. And what does that do as we improve our preferences for plant sources and reduce our preference for animal sources? And I think that's going to be interesting to observe over time. And finally, this doesn't stand in isolation. I don't think microbiomics can be used without taking into account various laboratory tests that are surrogates for inflammation, for genetics, for exercise, for age, gender, diet, and all of these could be put potentially into a prediction engine that would be helpful for diagnosis, for prognosis, and for stratification. So a lot of exciting stuff is coming out about the role of the microbiome in young onset colorectal cancer and in colorectal cancer in general. And I hope you'll follow this exciting literature as it evolves. Let me turn in my last few slides to sort of what can we do now in terms of practical applications and solutions for young onset colorectal cancer patients. I think the number one thing any healthcare provider can do, should do, must do is prevention. And we've known that colonoscopy is associated with finding cancers early, finding polyps and removing polyps that will never become cancer. Yet colorectal cancer screening has sort of plateaued off in the 60–70% range for most populations. We've known about this for 2 decades now, and we can't seem to sort of move that ball further. And so it's really incumbent on healthcare providers to make sure that there's appropriate screening. Screening for all people should start at age 50, but for high-risk individuals, that's anybody with a family history of colorectal cancer or a family history of polyps, or people with known hereditary syndromes, or people with known inflammatory bowel disease, screenings are different for those patients. For family history of cancer or polyps, you should start at least at age 40, and ideally 10 years younger than the youngest person in the family to get cancer or polyps. So if you have I have patients who are in their 40s who develop colorectal cancer, then their children should start in the 30s. I think lifestyle modification, the type of diet and lifestyle that I've described, more exercise, less red meat, less processed meat, more aerobic exercise, all of that is good for general cancer prevention. It's good for cardiovascular disease prevention. And so these are things that we should be encouraging our patients to do. And then finally, and I can't stress this enough, symptom recognition is really important. I can't tell you how many patients have symptoms of GI distress, abdominal pain, occasional blood in the stool, and all of it is either ignored by the patient or ignored by the provider because the expectation is, oh, you're young, you can't have cancer, therefore it must be, hemorrhoids or something else. And so it's important that symptom recognition and early diagnosis occur in cancer patients. As we've seen already, that this delay in diagnosis, the average number of doctors that a young patient sees is much greater than an average number of doctors that an older patient sees to get to a diagnosis. So this really needs to be corrected. This is actually a survey from the Colorectal Cancer Alliance, asking patients, how long did you experience symptoms before going to the doctor? And more than 75% of patients said they at least saw 2 different doctors. And almost 20% or more, actually almost 40% said they saw either 3 or 4 doctors or more before they were diagnosed. So again, very important that we make sure that we capture this. Recent guidelines from all of these different societies have changed. So American College of Gastroenterology, ACS, US Preventive Service Task Force, all of them are now recommending that colorectal cancer screening start at age 45, not at age 50. So that's a big change in terms of public health recommendations. And again, a reminder that that's for people with average risk, not for people that have a family history or of polyps or cancer or have IBD. And those patients start even earlier, depending on the exact type of risk. Another issue that our younger patients deal with is that at the time that they're diagnosed, which can be in their late 20s, early 30s, late 30s, Many of them are still creating families or may not even have started a family. And so it's important to refer these people to a reproductive endocrinologist to make sure that their fertility needs in the future are addressed. We need to emphasize sort of the risks of sexual dysfunction because many of these surgeries require pelvic interventions, which may lead to dysfunction later on. This is a very different population. They're employed full time. They may not have as much in savings as older patients do. They may not have as much insurance coverage as older patients do, may have a greater need for mental health and need help for depression. And all of these things need to be better addressed in the younger population. Kathy Yang recently put together this sort of graph of looking at sort of the whole aspect of treating colorectal cancer in younger patients, with a special emphasis on genetic counseling, financial guidance, fertility preservation, recognizing that they're still achieving their academic, professional, and career ambitions, emphasizing their mental and social well-being, and addressing sort of long-term survivorship in a different way than we would in older patients. And so that's important to keep in mind as well. And many of these solutions for young onset colorectal cancer can actually be deployed now. Education and awareness of both patient and physician, that's something we're doing tonight, and we should continue to do, spread it through our networks. Genetic testing, very important for all family members with colorectal cancer. So if you know of someone who has a family history of colorectal cancer, important to discuss both screening and potentially genetic testing. Screening guidelines have changed down to age 45, so let's remember that. We can deploy other solutions, whole genome sequencing for everybody, for instance, but there are barriers to doing that, particularly cost. Colonoscopy, as I mentioned, has reached a plateau, and so that needs to be considered. Risk-adapted screenings, and then streamlining and coordinating care and communication across sort of the different barriers to access is also important. And those barriers to access are actually very different in the younger population than they are in the older population. And so we need to take that into account as well. At the Cleveland Clinic, we've actually created a center for young onset colorectal cancer led by one of our colorectal surgeons, David Liska. And the goal here is to optimize outcomes for young patients with colorectal cancer, where we do a very coordinated multidisciplinary care, research, and education of those patients. We provide a clinical coordinator, genetic counseling, fertility preservation tactics, expand a surgical approach since younger patients are more likely to undergo surgery safely, provide psychosocial support, survivorship, integrative medicine, and we follow these patients prospectively to better learn from them, and I've shared some of the data that we've generated through research from this population as well. So hopefully I've introduced you to sort of this new mysteriously rising illness of young onset colorectal cancer, and you've learned something new this evening. To summarize, it's rising at alarming rates in the United States and many countries worldwide. The factors underlying this rise are not fully understood, may include obesity, diet, lifestyle, and may influence the gut microbiome and other aspects of the microbiome to lead to cancer. Our group has helped identify several clinical risk factors and geospatial regional differences, as I just showed you. In the United States, at least, Black and Hispanic patients are at greater risk, but the majority of young onset disease does still occur in white people. Hot and cold spots have been identified, specifically for young onset disease. Those hot spots are in the northern regions around the Great Lakes and Appalachia. And tumor microbiome analyses have identified microbial signatures associated with young onset disease with a particular role for Akkermansia. Lots of unanswered questions still remain. We still don't fully understand the exposome, the different environmental exposures that people experiences. Which of those specific elements are driving young onset disease? Is it exposure to antibiotics at a young age? Is it something prenatal or natal? We don't fully understand that. We don't understand genetic epigenetic signatures associated with this exposomal elements. We don't understand the specific periods of development that place the colon at risk for cancer. We've often linked obesity to cancer and to colorectal cancer, but how does that link actually happen? We don't understand that. Is it inflammation? Is there something about obesity? Is it about glucose control? We don't really understand any of those aspects. The role of the microbiome, they're beginning to understand, but we're not quite there yet. And most importantly, what interventions, especially diet and lifestyle, resource neutral or resource poor interventions, can mitigate this rise? These are really important questions, and I hope you'll join me in taking part in this field as it evolves over the next few years in terms of treatment.